I'm Dr. Rod Shelley. I started in practice in '76. I live in California. I've been retired for a decade or so. But in my early time in chiropractic, I was one of the lucky ones to have Dr. DeJarnette come and work at my office. And I'm going to share with you a couple of things that I noticed there while he was working in my office and share them with you today, in case it could add to your toolbox for helping patients coming into your office, and for you students of the work to maybe add to the toolbox after the foundational things are covered. And it's called latent sciatica. I'll share with you how I first came upon this. I was one of the offices that brought every case that I could to Dr. DeJarnette, not just the cranial cases. And so there were some people that had all kinds of different conditions, and it was good for me to see how he handled them. And one of the things that I noticed that he did when I had brought in a low back case is he had the person facing down, and after he'd checked for category 2, then he'd flip them over, and he would palpate on 3 places in the body, and I'd say, okay, where's that? And oh, that's in the middle of the calf. Where's that? Oh, that's in the middle of the thigh. Oh, is that one the dollar sign? No, it's just above the dollar sign, he told me. And I said, okay, what's that? And he said, well, it's just checking the sciatica. Sometimes you find it, sometimes you don't. So from that time on in my practice, I added that to my analysis of rubbing all those 3 places on both sides for every case, regardless whether they had any kind of finding of category 3 or any category. It was just part of my normal operating procedure. And what we found is that not everybody that has this indicator active has any kind of low back pain or any kind of manifestation of category 3 at all, but they have this latent sciatica indicator. And so that same visit, I saw Dr. DeJarnette do the cough test and place the blocks accordingly, and then said, Shelley, hold that guy's leg, hold his leg. Now told the patient, pull on the top of the table. Okay, so I'm holding on the leg that had the sciatica indicator. Patient's pulling on the top of the table. Help me out here, Charles. And I'm trying to get to the spot where it's showed. And then, cough, Major says. So the patient coughs, and I'm holding the traction, and I felt a release in the person's low back through the leg that I was pulling on. I felt it like go pop, and I felt the leg lengthen, and then he went back up and he checked them. He says, all right, how are they? And the patient said better, and then he flipped him over and did the cranial adjustment. So that's what gave me the idea that this was an indicator that maybe I should be checking. How did I screw this? Okay, tell me when I'm back. Okay, all right. Then during that time, I was also very interested in traction, different kinds of traction techniques. You know, I think at that time we were hanging people upside down, you know, and trying to elongate the spine, different forms of traction. But the way that this test came about was I'd been doing the cervical compaction test faithfully for years, and I noticed on some cases that when I compacted them, they went from being able to lift their legs to completely unable to lift their legs. But then sometimes when they couldn't lift their legs at all, I would traction them, and then they could lift their legs. So, you know, I had to wait a few months till Major came back to the office, and I said, hey, what does this mean? I mean, what do you think of this? And he said, oh, sure, that's, you know, if you do that, and then that means that there's some compression in the spine, and so, and by you relieving it, you give them the strength. And so then I added the cervical traction test to the treatment, and from that time on, thanks, from that time on in my practice, when he would come into the office, I would see him doing this cervical traction as well as the compaction on the patients, and then sometimes even give a little tug to release them. So here's what we have on our findings. Leg lift without cervical compaction. If it's difficult to lift, we may have a lumbopelvic involvement. If it's easy to lift, it's not conclusive. Leg lift with cervical compaction, if it's difficult to lift, it's likely a lumbopelvic involvement. If it's easy, then it's likely a cervical spine involvement, but it could be hypermobility of the segment. So this would be a time when I would find including some nutritional support to help laxity of the ligaments could be helpful too. But leg lift with cervical traction, if it's difficult to lift, then it's definitely some type of instability in the ligaments. And I would get this extra reading from hypermobility, different other segments in the body just not working well. Motion studies of the x-rays, you'd see that segments would just not go in their normal flow. George's line would be broken. I did motion studies of the lumbar and the cervical spine. And if it was easy to lift, then I assumed that there was some kind of disc involvement, most typically in the low back. Oftentimes these same people then had the latent sciatica regardless of their category. So it became part of my my procedure to test for the latent sciatica, test for the cervical traction, and then apply the treatment when it was appropriate. And for me, when it was appropriate was when the category 2, I didn't feel like if there was an active category 2 that I'd be aggravating to it. On one particular case, it was a 38-year-old male. He had had low back pain. He had been a category 2. His back pain was gone. He was coming in basically out of respect for me, telling him to, hey, come on back in and let's check you out. And while he didn't have any symptoms, he continued to have irregularity of his bowels and some erectile dysfunction. So I went ahead and did the testing and found that he did have the latent sciatic indicator. I followed the example that DeJarnette had showed me and found the SB plus or minus, placed the blocks accordingly, and then pulled on the active indicator leg and asked the patient to cough while he was pulling on the top of the table. And it was in this experience that also that I felt this release. You may not find it every time, but sometimes it's really obvious and it's satisfying to the patient and of course me. When I then flipped them over, they were able, after this release and the sciatic indicator going away, I was able to then do the traction and the compression test, and they were able to lift up their legs more effectively in both ranges. I saw the patient a few days later, and he continued to have some latent sciatic indicators. I did the same treatment. There wasn't a release on this time, and basically the case just progressed from there. The one thing to be sure of when you're doing this, if a person's had a category 2 in the past, you want to be careful when you're placing the blocks, because that position can have an effect of re-separating or re-aggravating the SI joint. So it's something to be careful about. Following week, the patient didn't have any latent sciatic indicators, was still an SB+. I treated them as if he had latent sciatic indicators and placed the blocks and traction on the leg. This is the progression through the case. Additionally, when Dr. DeJarnette was in the office, he used the R+C factors quite a bit. When we'd be placing the blocks after the latent sciatica, he would go up and check on the styloid and the lateral mass of the atlas and C2 as they relate to the different vertebra. Then he would pull out a block and rotate hold the spinous process in the direction that was indicated by the R+C factor, And I found in my practice later that this is very effective for clearing out the latent sciatic indicators. A week after a couple of these treatments, the bowel movements were better, and I euphemistically said his other bodily functions seemed to be working also. So happy days are here again. So here's a case where patients come to you and they may not have symptoms, but you need to let the indicators guide what you're doing. And to remember that there's so many things that we can do, like in the CMRT class projects that we heard earlier, how valuable it is to look at the body as a whole, not just a symptomatic pattern. These indicators work whether a person speaks English or horse or dog or any other language, because you can check the indicators and they're going to talk to you about how the body needs to be approached. Do we have another slide? So I think I covered it.
Excellent.
Thank you. The offices that brought every case that I could to Dr. DeJarnette, not just the cranial cases. And so there were some people that had all kinds of different conditions. I was one of the lucky ones to have Dr. DeJarnette come and work at my office. And I'm going to share with you a couple of things that I noticed there, why he was working in my office, and share them with you. I'm Dr. Rod Shelley. I started in practice in '76. I live in California. I've been retired for a decade or so, but in my early time in chiropractic, the foundational things are covered. And it's called latent sciatica. I'll share with you how I first came upon this. I was one of the today, in case it could add to your toolbox for helping patients coming into your office, and for you students of the work to maybe add to the toolbox after.